I'd like to thank the Abstract Committee for allowing us to present our work. I'll be presenting my abstract titled Intraoperative Use of FLIP is Associated with Clinical Success following poem for achalasia. I have nothing to disclose. The disclosures of my co-authors are as listed. Achalasia is a rare neurodegenerative esophageal motility disorder that's characterized manometrically by abnormal peristalsis and a non-relaxing lower esophageal sphincter. Current treatment modalities include pneumatic dilation, as seen on the far left, Heller myotomy, seen in the middle panel, or peroral esophageal myotomy, as shown on the far right. Goal of these treatments is to reduce lower esophageal sphincter tone, but we've previously not had a way to calibrate this in real time in order to assess our treatment effect. This is where the functional luminal imaging probe, or FLIP probe, comes in. The FLIP system uses catheter-based technology with a working distal end that houses a pressure transducer, balloon, and electrodes. When placed across the esophagogastric junction, or EGJ, the system calculates a cross-sectional area and a pressure. It is this cross-sectional area over the pressure that generates a measure of compliance referred to as the distensibility index, or DI. We've previously shown that DI increases over the course of myotomy, either during Heller, as shown in the far left, or during poem, as seen on the right. Previous studies have examined the utility of distensibility index as a marker for clinical response following treatment for achalasia.
In this study, the authors noted that in patients who previously underwent treatment for achalasia, either by pneumatic dilation or Heller myotomy, the majority of patients with a positive clinical response had a DI above 2.9. This also was shown to correlate with barium retention on esophagram.
So DI has been shown to be a useful measure of LES compliance that correlates with clinical outcomes. However, at this time, it is unknown how intraoperative FLIP is being used in real time by the surgeon when performing a myotomy, and what, if any, clinical impact the use of FLIP may have. So our hypothesis was that the use of intraoperative FLIP would result in superior clinical outcomes following poem. Our objectives were twofold. First, we wanted to assess the frequency of FLIP-directed myotomy, and second, we hoped to compare the clinical outcomes of patients who underwent intraoperative FLIP during poem for achalasia versus those who did not have intraoperative FLIP performed. In order to achieve these objectives, we performed a retrospective cohort study of patients undergoing poem at our institution from 2012 to 2017. The use of intraoperative FLIP was based solely on catheter and technician availability, resulting in 2 natural patient cohorts.
All available operative videos of patients in the FLIP cohort were reviewed for the performance of an additional myotomy. Pre- and postoperative symptom questionnaires and physiologic studies were collected routinely.
Differences between the FLIP and no-FLIP cohorts were assessed by chi-square tests. There was a total of 143 patients included in the study, 82 that did not have intraoperative FLIP, and 61 that did have intraoperative FLIP.
The only significant difference between cohorts was a higher proportion of males in the FLIP group, though it is worth noting that there was a higher proportion of type 3 achalasia in the no-FLIP cohort. At this point, we reviewed all available operative videos for patients in the FLIP cohort.
This video review demonstrated that nearly 2/3 of patients had an additional FLIP-directed myotomy. These results do imply that the FLIP catheter is being used in a majority of cases to direct the extent of myotomy.
When further examining patients who underwent additional myotomy compared to those who did not undergo additional myotomy following FLIP, there were no significant differences in clinical outcomes at 12 months based on Eckert score, and there were no significant differences in initial induction distensibility index or final post-myotomy DI.
At this point, we turned our attention to clinical outcomes between cohorts, specifically clinical failures at 12 months, defined as an Eckert score greater than 3. This analysis demonstrated that patients were significantly less likely to have a treatment failure if they had intraoperative flip than those patients that did not. As a sensitivity analysis, we excluded patients with type 3 and variant type achalasia, and the raw difference in clinical outcomes persisted, though it was no longer statistically significant. Interestingly, despite the difference in clinical outcomes as measured by Eckert score, there were no significant differences in postoperative physiologic studies.
Specifically, there were no differences in barium retention on time barium esophagram, esophagitis on endoscopy, abnormal pH studies, or in manometric IRP.
In summary, flip usage resulted in the surgeon performing additional myotomy in over half of cases, and the use of intraoperative flip was associated with improved clinical outcomes as measured by Eckert score. There were no significant differences found in physiologic outcomes between the flip groups. Limitations include the fact that this was performed at a single site with a single surgeon, which limits the generalizability of our results. There's a low event rate specifically for clinical failures, making it difficult to perform more comprehensive analyses, and our follow-up for physiologic studies is low. We're also unable to objectively compare the extent of myotomy between the two groups. In conclusion, the use of intraoperative flip may assist the surgeon in ensuring adequate myotomy at the completion of the case and may improve clinical outcomes in patients undergoing surgical myotomy for achalasia. Our future work may focus on obtaining more complete physiologic follow-up for these patients in this cohort, enabled in order to better correlate with flip measurements. We may perform a similar study assessing outcomes with flip during Heller myotomy, and would be useful to assess external validity with additional surgeons or at other centers. I'd like to thank my mentors in the Department of Surgery, Dr. Eric Hungnes and Dr. Ezra Teitelbaum, and our GI colleagues. Thank you.